Wound healing and wound management are critical topics for surgeons to understand. Every time we bring a patient to the operating room, the implicit assumption is that the patient can heal our incisions and our anastomoses. Surgeons are also consulted on many patients around the hospital with open or poorly healed wounds as well. And so this is a topic I think surgeons need to understand critically well. In this talk, we're going to go over the basic mechanics of wound healing, and then we'll talk about many of the factors that impair this healing process. We'll go over some specific complications of wound healing, like contractures and keloids and adhesions. And lastly, we'll finish up by talking about some basic wound management principles. Wound healing is customarily divided up into three distinct phases. The first phase is the inflammatory phase. In this phase, the wound bed is prepared and the cells that are important to wound healing migrate into the wound. The proliferative phase is the phase where the wound matrix is laid down and collagen is deposited into this matrix. Wound contraction and reepithelialization also occur in this phase. The last phase is the remodeling phase. This is an ongoing phase that carries on throughout the patient's life. In this phase, collagen is continually broken down and replaced. In an injured patient, hemostasis and wound healing are two critical functions that must occur. And initially, they share many common features. Both processes start when blood is exposed to subendothelial collagen. This initiates a biphasic vascular response. The initial response is vasoconstriction, and this goes to supporting the hemostatic mechanism. But shortly thereafter, vasodilation occurs, which allows many blood-borne factors to enter the wound. In particular, platelets are critical for both hemostasis and the inflammatory phase of wound healing. Platelets produce multiple essential cytokines that control the early phases of wound healing. Chief among these are platelet-derived growth factor and transforming growth factors alpha and beta. The end result of the coagulation cascade is a stable fibrin cross-linked platelet plug. The fibrin provides a scaffold for the migration of inflammatory cells into the wound. Thrombin also plays several key roles in wound healing. Early on, it facilitates vascular permeability and the migration of cells into the wound. Later on, it supports the processes of reepithelialization and angiogenesis. Neutrophils are the first inflammatory cells to migrate into the wound. They migrate in response to various different chemotactic factors, including bacterial products, C5a from the complement cascade, platelet-derived growth factor from platelets, and interleukin-1 and tumor necrosis factor from tissue macrophages. Neutrophils peak in the wound by around 24 to 48 hours, and their job is wound debridement and to kill off any invading microbes. As important as neutrophils are, they are not mandatory for wound healing since they play no role in collagen synthesis. So if you ever had to operate on a neutropenic patient, you would certainly have the expectation that they will heal their wounds, but they would have an increased risk of wound infections. By post-injury day 3 or 4, macrophages are now the dominant cell in the wound. Unlike neutrophils, macrophages are absolutely essential for wound healing, and they oversee all the different activities that occur during the proliferative phase. Macrophages carry out these oversight activities by producing many different cytokines. Some of the important activities under macrophage control include angiogenesis and activating fibroblasts to secrete collagen and wound tissue matrix. Macrophages also continue to serve a wound debridement function as well. Another absolutely essential cell during wound healing are T lymphocytes. These cells peak in the wound at about 1 week, and although they're essential, their exact role is unclear. The proliferative phase of wound healing is characterized by fibroblast migration into the wound. And by post-injury day 4 or 5, the fibroblast is now the dominant cell. Fibroblasts arrive in the wound under the influence of platelet-derived growth factor, and they migrate into the wound along a fibronectin network. The various activities of fibroblasts are controlled by cytokines secreted by wound macrophages. Angiogenesis is a proliferative phase activity that is essential to wound healing. It's stimulated by the hypoxic and acidic wound environment. New blood vessels sprout off from capillary endothelial cells, and the process is controlled by multiple cytokines secreted by tissue macrophages. Some of these cytokines include vascular endothelial growth factor and tumor necrosis factor alpha and tumor necrosis factor beta. Fibroblasts are responsible for secreting the wound matrix. The wound matrix consists of a class of molecules called proteoglycans, and some of the important ones include hyaluronic acid, chondroitin sulfate, and heparin sulfate. The wound matrix is critical to wound healing, since it provides the structure onto which collagen will be secreted and then subsequently assembled into fibrils and then fibers. Collagen is secreted by fibroblasts under the direct control of the macrophage. There are many different types of collagen known, but types 1 and 3 are most important for wound healing. Collagen contains 2 unique amino acids, hydroxylysine and hydroxyproline. Each collagen fiber consists of 3 separate polypeptide chains, each of which is twisted into a right-handed helix. Collagen is secreted into the wound matrix in a precursor form. It then undergoes several transformation steps before it becomes the mature collagen fiber. The entire synthesis and secretion of collagen requires adequate amounts of vitamin C. In addition, sufficient oxygen and protein must be available in the wound as well. The fibroblast produces several other critical molecules. Elastin gives the wound pliability, which allows it to stretch and recoil. Fibronectin is a critical matrix attachment protein. It facilitates additional fibroblast migration into the wound, and importantly, it provides a framework for the migration of epidermal cells during wound epithelialization. Another critical aspect of wound healing is wound contraction. This process begins as early as post-injury day 4 or 5, and it consists of the wound edges being pulled towards the center of the wound. This pulling action is facilitated by a cell called the myofibroblast, which contains actin and myosin filaments. Wound epithelialization is under the control of epidermal growth factor. The basal layer of the wound edge epidermis is the proliferative layer, and within 24 hours it becomes noticeably thickened. The proliferating basal cells are then able to detach and migrate out into the wound. Hair follicles and sebaceous glands are also able to serve as a secondary source of epithelial cells. The epithelial cells then migrate until they contact cells migrating from a different direction. Ultimately, this process continues until a new multi-layered epidermis is formed. Small wounds, like a primarily closed surgical incision, are re-epithelialized within 48 hours. The new wound epithelium isn't quite like the normal uninjured epithelium, either functionally or cosmetically. The regenerated epithelium contains fewer basal cells, and importantly, it does not have any REIT pegs. This makes wounded tissue much more vulnerable to shearing than unwounded tissue. Cosmetically, there's a big difference as well. Wounded tissue is thicker at the edges and thinner in the middle. The last phase of wound healing is wound maturation and remodeling. By 21 days, the collagen content of the wound is maximized, but the wound isn't very strong at this point. It only has a bursting strength of about 15% of normal skin. However, by 6 weeks, the wound is about 80 to 90% as strong as it will eventually get. This forms the basis for the customary surgical recommendation that a patient is able to go back to a physical job or heavy exercise by around 6 weeks. The strength increase in the wound from 21 days to 6 weeks comes from greatly increasing the number of crosslinks between collagen fibers. The collagen fibers also become better organized along stress lines. It's a common misconception that scar tissue is stronger than normal skin, but this isn't so. The bursting strength of scar never reaches that of normal skin. And the remodeling process is a lifelong process. Collagen is continually being broken down and new collagen being laid down. With that as a basic overview of the mechanics of wound healing, let's now discuss some of the factors that will negatively affect wound healing. Wound infections greatly impair the healing of surgical incisions. It takes greater than 10 to the 5th bacteria per gram of tissue to develop a wound infection, but this will be decreased by the presence of adjuvant factors like foreign bodies, hematomas, and necrotic tissue. The best treatment of a wound infection is, of course, prevention. Surgeons need to use meticulous technique, and we need to use the correct preoperative antibiotics for the case at hand. In addition, we need to exercise good judgment regarding which wounds can be closed primarily and which should be left open to heal by secondary intention. The most common reason for poor wound healing is wound hypoxia. For a wound to heal, the patient must be able to deliver sufficient oxygen to the wound. This implies that there's an adequate circulating blood volume and an adequate cardiac output. In addition, the local vasculature must be intact as well. As long as the patient is normal volemic, anemia doesn't affect wound healing unless the hematocrit drops below 15. Smokers are notoriously poor wound healers. This is because chemicals in the cigarette smoke stimulate vasoconstriction, and this in turn decreases the amount of oxygen delivery to the wound. Operations in radiated fields are always plagued by poor wound healing. Radiated tissue has a characteristic appearance. The overlying epidermis is thin and dried out, whereas the underlying dermis is extremely fibrotic as a result of increased collagen synthesis. In addition, the medial layer of small arterioles becomes thickened and can eventually occlude, leading to decreased vascularity of the wound. And it's this combination of decreased vascularity and increased fibrosis that is so damaging to wound healing. This ultimately results in decreased platelet and inflammatory cell migration into the wound. The net result is decreased cytokine production, which impairs all aspects of wound healing. Lastly, to add insult to injury, the decreased vascularity of the wound leads to a greatly increased infection risk in irradiated wounds. Wound healing is very energy intensive and requires adequate calorie intake for the process to proceed. In addition, sufficient amino acids must also be available to synthesize collagen and wound matrix. Besides adequate calories and protein, multiple vitamins and minerals must be available as well. Vitamin C is critical for collagen synthesis, and vitamin A supports wound epithelialization, proteoglycan synthesis, and overall immune function. Vitamin D is necessary for fractures to heal, and zinc is a critical mineral since it's a cofactor in many enzymes critical to the wound healing process. Patients with metastatic cancer also have poor wound healing. This is a multifactorial process. Poor oral intake can lead to malnutrition, and the cachexia of cancer can lead to greatly increased protein catabolism. Lastly, advanced cancer patients have impaired immune function, and they may even be anergic. Ultimately, this can result in macrophages that do not migrate into the wound or do not function normally once they do arrive. Observational evidence certainly shows that older patients take longer to heal than younger patients. As a patient ages, the incidence of wound dehiscences and incisional hernias increase, and the amount of force required to cause these disruptions decreases. It's likely that the comorbidities that accrue with age play a significant role in this process. Diabetics are notoriously poor wound healers, and there are likely several explanations for this. The first is that diabetics have a greatly increased risk of wound infections, and we've already seen how wound infections impair healing. Diabetics are also relatively immunosuppressed, and they have impaired white blood cell chemotaxis and phagocytosis. Lastly, diabetics have both large vessel and small vessel arterial disease, and this leads to a relatively hypoxic wound environment. Better pre-op glucose management can improve wound outcomes. The most likely explanation for this will be that tighter glucose control can lead to a decreased risk of wound infections. Many of our patients are on glucocorticoids for all manner of inflammatory conditions, and these drugs greatly inhibit all aspects of healing. Steroids decrease inflammatory cell function, and this ultimately leads to decreased wound cytokine production. Some surgeons attempt to counteract these effects by administering topical vitamin A. Vitamin A is known to stimulate collagen secretion and facilitate re-epithelialization. Chemotherapy impairs DNA synthesis and replication, and it affects rapidly dividing cells the most. This will have a great effect on our healing wound, since cell turnover and protein synthesis is so high. In addition, if the patient is neutropenic, they have a higher risk of wound infection. And so ideally, we'll wait for at least 3 weeks after the last round of chemotherapy before proceeding with elective surgery. Obese patients have a much higher risk of wound complications. Their rates of dehiscence, incisional hernias, wound infections, and seromas are all much higher than the non-obese population. Obese patients also have a much higher rate of anastomotic leaks. And all this is true even when comorbid conditions like diabetes and cardiovascular disease are controlled for. Let's now get into some specifics for some common wound healing complications. Wound contractures occur when an open wound crosses a joint. The normal healing process of wound contraction can lead to a decreased range of motion in the joint and ultimately resulting in a joint that's lost considerable function. This is most commonly seen in burn wounds, but any open wound can do this. The way to prevent this problem is to use skin grafts across joints, and full-thickness grafts are more effective in preventing contractures than a split-thickness graft. While we're waiting for the grafting to occur, the joint should be splinted into a position of function. Here are several images of contractures that have occurred after burn injuries. It's easy to see how devastating these contractures are from a functional standpoint. Of course, prevention is best with early skin grafting, but to manage an established contracture will require releasing the scar to free up the joint and then the placement of a skin graft, ideally a full thickness graft, which leads to better function. Hypertrophic scars and keloids are problems of excessive healing. A hypertrophic scar rises above the level of the skin, but remains confined to the wound margins. A keloid extends well beyond the margin of the wound. As you can see from these images, hypertrophic scars and keloids differ only by degree. The hypertrophic scar is too prominent for most patients' desires, but the incision itself is nicely healed and the scar is confined to the wound margins. The keloid, on the other hand, represents an overly exuberant healing process, with the scar spilling out well beyond the wound margins. Besides being unsightly, keloids can cause a few other problems. One is that they often itch quite a bit. The second is that if they're near a joint, they can cause a functional problem. Both hypertrophic scars and keloids result from excess collagen synthesis, and increased levels of transforming growth factor beta have been implicated in this process. If a patient does develop a hypertrophic scar, you can reassure them that these scars become less prominent over time. But keloids are permanent and do not regress. The management of keloids depends on whether we're trying to prevent the formation of a keloid or whether we're trying to treat an established keloid. If we have a patient who's known to form keloids, one effective strategy is at the end of the case to inject the new incision with triamcinolone, which is a long-acting steroid. The goal, of course, is to impair the healing process here. This will often be combined with the use of pressure dressings as well. If the patient has an established keloid that's causing them significant issues, the first thing to know is that excision alone doesn't work. The keloid will always recur. Typically, the first thing that's done is a standalone triamcinolone injection. That may in itself give enough relief to the patient. If not, then re-excision can be combined with another steroid injection. Radiation treatments by themselves are ineffective as well, but there are protocols to combine them with re-excision. Let's now talk about wound dehiscence and wound evisceration. Although these terms can be used to describe any type of incision, in general surgery, we usually use these terms to describe abdominal incisions. And so for our purposes, a dehiscence is a fascial separation, but the skin remains intact. An evisceration occurs when both the fascia and skin separate, and sometimes we can actually see the bowel in the wound. Dehiscence occurs when abdominal wall tension overcomes either fascial strength, suture strength, or knot security. Most of the times, when you re-explore a patient for a fascial dehiscence, you'll find that the suture is intact, but that it is pulled through the fascia as a result of fascial necrosis. And fascial necrosis occurs when the sutures are placed under too much tension. Since tension is proportional to incisional length, you typically find dehiscence in the longer incisions, with most being greater than 18 centimeters. The risk factors for dehiscence are the risk factors for poorer wound healing that we've just talked about. There is one additional risk factor that's relevant in abdominal surgery, and that's whether the patient develops postoperative ascites or has a prolonged ileus. This increased distension will increase the tension on the wound, which will increase the risk for dehiscence. Abdominal dehiscences typically occur on postoperative day 8 or so. The patient will usually report profuse drainage from the wound, and it's classically described as salmon pink. Sometimes the patient may report that they heard a popping noise when they tried to get out of bed or after they coughed or sneezed. The diagnosis is usually straightforwardly made clinically, but sometimes a CT or ultrasound can be useful, especially if the patient has a large abdominal wall. Management is dependent on how stable the patient is and whether they have eviscerated or not. So if we have a stable patient who has a dehiscence without evisceration, then the patient should be brought back to the operating room for a fascial closure. If you don't close this, then the patient will develop an incisional hernia. If the patient is too unstable to go back to the operating room and they haven't eviscerated, then we'll usually cover the draining wound with sterile dressings and place an abdominal binder. The goal here is to prevent evisceration. Lastly, if the patient has eviscerated, and so if they have exposed bowel, this bowel should be covered with sterile towels, and these patients must go back to the OR for definitive closure. The classic way to repair an evisceration is with the use of retention sutures. This is a mass closure that involves all layers of the abdominal wall, including skin, subcutaneous tissue, fascia, and muscle. These sutures are then tied down over a bolster. The goal of this type of repair is to prevent another evisceration, but it doesn't prevent another dehiscence. Retention sutures are painful and they cause skin necrosis as well, and so they're not a perfect solution to a difficult clinical problem. As an aside, what is the optimal fascial closing technique? And I must say, I really don't have a good idea on this. I've been closing abdominal incisions for close to 30 years, and during this time I've been exposed to running versus interrupted closures, using permanent or dissolvable type sutures. Also, varying size tissue bites have been popular during this time. A recent clinical trial called the STITCH trial reported better results using a running number 1 or number 2 PDS suture where they did a mass closure. They incorporated all layers except the skin. And they used relatively small bites of 5 millimeters while advancing 5 millimeters. They felt the optimal suture length to wound length was greater than 4:1. The development of peritoneal adhesions can be considered a wound healing complication. Adhesions develop from peritoneal injury as a result of surgery, trauma, or intra-abdominal infections. The injury leads to an inflammatory response, which ultimately leads to fibrin deposition on the bowel surfaces. This fibrin then glues the bowel together. The fibrinolytic process will break down many of these filmy adhesions, but any that are left will ultimately become permanent as collagen gets deposited within them. This typically occurs within about a week of injury. Adhesions make subsequent laparotomies more difficult and risky, and adhesions are also the most common cause of small bowel obstructions. Preventing adhesions has been a long-standing goal of abdominal surgeons. One approach is to reduce the overall amount of tissue trauma, and minimally invasive surgery like laparoscopy helps achieve that goal by reducing the total length of incisions. Surgeons have also lavaged the abdomen at the end of their cases with many different solutions. Steroids, chemotherapy agents, heparin, fibrinolytic agents have all been used, but to no great effect. Barrier methods are something that's being tried right now. There are several in clinical use. The common ones are Seprafilm and Intercede. These are placed between the abdominal wall and the bowel, and they do seem to prevent adhesions from the loops of bowel to the incision. However, they seem to be associated with increased risk of intra-abdominal infections, and they definitely are associated with a higher rate of anastomotic leaks if the Seprafilm is placed over the anastomosis. In addition, these agents are expensive, and so they haven't reached the level of widespread clinical use. Surgeons are considered the experts in wound management, and we are consulted to see a variety of patients with open and non-healing wounds. And so we'll finish this talk by discussing the basic principles of wound management. The most basic thing you can do to an open wound is wash it out. Irrigation decreases the bacterial load and also removes any dirt, debris, foreign bodies, or necrotic tissue that may be present. A low-pressure bulb syringe is adequate for most situations, but occasionally you'll find it useful to use a high-pressure pulse lavage system for very contaminated wounds. The next step in wound management is debridement. All devitalized or contaminated tissue must be removed, and the debridement must be carried down to healthy bleeding tissue. Sharp surgical debridement with a knife, scissors, or curette is the primary technique. But on occasion, enzymatic debridement with a collagenase like Santal is a good option in patients who aren't surgical candidates. Our plastic surgery colleagues often make use of biological debridement, otherwise known as maggot therapy. This can be used as a bridge between debridement procedures or on chronic wounds when debridement cannot be performed in the operating room. Surgeons have been using topical agents on open or infected wounds for thousands of years. Honey is mentioned in Egyptian papyri and has a very broad spectrum of antimicrobial activity. This is based on its high osmolarity and its high concentration of hydrogen peroxide. Medihoney is one agent that's available to us clinically. Silver has also been known for hundreds, if not thousands of years, to be useful in the prevention and treatment of infected wounds. Silver is bactericidal and active against most common pathogens, including methicillin-resistant staph, vancomycin-resistant enterococcus, and yeast. Silver sulfadiazine, or Silvadene, is the most commonly used agent on burn wounds. One issue with using silver on wounds is that it requires a delivery system, and so silver-based wound dressings are applied as a cream, a foam, or an impregnated dressing. Surgeons use all manner of antibacterial solutions on open wounds. Some of the common ones in use are acetic acid, Dakin solution, and betadine. One issue with these agents is that they are partially cytotoxic, and so they impair wound healing by impairing the function of the cells we need to heal wounds, like fibroblasts and macrophages. So their efficacy is not well established. One use case, however, where Dakin solution is commonly employed is on a wound that's contaminated with Pseudomonas. Antibacterial ointments like bacitracin, Neosporin, or Polysporin are very frequently used. They're soothing to apply, and they function as an occlusive dressing. They're quite useful for small burn wounds or small open lacerations. Topical growth factors to speed up the healing of open wounds is an area of active pharmacologic research. Chronic wounds like diabetic foot ulcers and venous stasis ulcers are very slow to heal and are very costly to the medical system. Regranex, or platelet-derived growth factor, is an FDA-approved drug for chronic diabetic foot ulcers. But many more of these agents will be coming online soon, including some that may be beneficial in chronic venous stasis disease. An open wound will require some type of wound dressing. The purpose of this dressing is to provide a warm, moist, clean environment that is conducive to ideal wound healing. Our ideal dressing should provide several functions. It needs to absorb excess moisture to prevent maceration. It should eliminate dead space, and it should prevent bacterial invasion or proliferation. Wound dressings come in two primary types, occlusive or absorptive. Occlusive dressings are a good choice for most open wounds. This type of dressing facilitates rapid epithelialization and facilitates moisture retention. These dressings also serve a mechanical protection function as well as a barrier to bacteria. A hydrocolloid like Duoderm is often chosen for early-stage pressure ulcers since it functions as a mechanical protection barrier. Alginates absorb fluid and are a very good choice for moist wounds like venous stasis ulcers. Hydrogels are a good choice for desiccated wounds. Absorptive dressings are chosen for wounds that produce a lot of exudate. The most common use case would be extensive venous stasis ulcers. The traditional surgical 4x4 gauze that is often applied to these wounds loses all effectiveness when it gets saturated. The newer absorptive dressings are foam-based and can absorb a very large amount of fluid. They also have the benefit of being non-adherent, so they're much more comfortable for patient use. Negative pressure wound devices, better known as wound vacs, have proven to be incredibly valuable in the management of complicated wounds. Surgeons have found use for these devices in taking care of large soft tissue wounds, pressure ulcers, open abdomens, and even complicated enterocutaneous fistulas. Wound vacs perform many valuable wound care functions. They facilitate removing exudate and infectious materials. They reduce edema. They create a moist wound environment. And they promote increased capillary blood flow, angiogenesis, and the formation of granulation tissue. Hospital administrators like wound vacs because they reduce overall hospital stay and cost, and this efficacy has been documented in clinical trials. Some of the downsides of wound vacs are that they can be painful to some patients, and some patients won't tolerate them. Patients also will be tethered to a portable pump for a period of time as well. Large wounds can occasionally result in excessive amounts of fluid loss, and if the patient has to bear the cost of the wound vac, these devices can be expensive. Hyperbaric oxygen has found use in the management of certain types of chronic wounds. The physiologic basis for hyperbaric oxygen is that wound ischemia is the most common cause of wound healing failure. Inside the hyperbaric chamber, 100% oxygen is pressurized to 1.5 to 2.5 atmospheres. This allows tissue oxygen levels to rise to levels that can be as high as 10 times baseline. The effects of this elevated oxygen persist for 2 to 4 hours post-treatment. These treatments last anywhere from 60 to 120 minutes, and they're repeated over multiple sessions. The most common indication for hyperbaric oxygen is a non-healing diabetic foot ulcer. Since most of these patients also have vascular disease, they need to be evaluated first by a vascular surgeon. Patients who have unreconstructible vascular disease are not HBO candidates since they will not see an increase in wound oxygen levels. Appropriately chosen candidates do seem less likely to require a future amputation. Other less common indications for HBO include compromised flaps and grafts, radiation injury, or chronic osteomyelitis. An essential component of the HBO evaluation is the transcutaneous oxygen pressure measurement, better known as TCOM. In this test, sensors are placed adjacent to the wound. The TCOM is first measured at room air, and a value of less than 35 millimeters of mercury indicates tissue hypoxia. The patient is then placed in the hyperbaric chamber and the TCOM measurement repeated. A value greater than 200 millimeters of mercury in the chamber suggests that the patient would benefit from HBO treatments. HBO therapy is not without its complications. Many patients are claustrophobic, and they simply do not tolerate lying in the enclosed chamber for 1 to 2 hours at a time. Middle ear barotrauma is the most common problem seen, and every patient needs an otoscopic exam before entering the chamber. The most serious complication is the development of a pneumothorax, which may progress to a life-threatening tension pneumothorax. And lastly, some patients develop seizures from oxygen toxicity. Congratulations on making it to the end of this talk. I've listed the URL to this course's companion webpage above. I also have a number of other YouTube videos on basic surgical care, that you're free to check out as well. Once again, thanks for your attention.